to go another story making this.
Well, now. There you go.
Hello. Welcome to Fertility Fact or Fiction. I am your host, double board certified reproductive endocrinology and fertility specialist, Dr. Rahi Victory, and my good co-host, the quote unquote Dr. Tarek Ibrahim.
Dr. T's in the building.
And we are here today to share lots of information with you. Tonight, we've got an exciting show. We're actually going to review the guidelines for the management of IVF pregnancies for those of you that have become successful or are looking forward to success and want to know what pregnancy is going to be like. So we're going to talk about that because there are some important things and probably some changes we need to implement both in Ontario and elsewhere to try and improve the care for our IVF patients. So we're going to review that. Just before we get into that, I want to comment on a post I actually recently put up talking about whether or not recurrent implantation failure exists. So they have this great study where they looked at over 30,000 embryo transfers in over 11,000 patients, and they talked about whether or not recurrent implantation failure actually exists. So what they showed in that study was that with 6 embryo transfers, you could get over 60, almost 70% chance of pregnancy and live birth. And then when you went up to 10, it got up as high as almost 80%, which is great. I mean, that's good information to have. The problem is you need 6 embryo transfers or up to 10 embryo transfers to get success rates that are lower than what we're getting with just 1. And the other problem is that's freaking traumatic for people. Making people go through 6, 8, 10 embryo transfers is financially traumatic. It's emotionally traumatic. It's physically traumatic. That's a lot of progesterone to be sticking into your buttock. So the reality is we need to do better for patients. And more so, there are ways to make this journey better. You don't have to try 6 untested embryos in order to get success. PGTA can help. We know that because other studies show that you get a higher success rate with PGTA tested embryos. We know that things like infusions can help. I'm going to be reviewing that next week. There's a new study that did a review of PRP, HCG, Neupogen washes, all shown to be statistically significantly beneficial. We know that immune testing and treatments can work. We know that the microbiome is huge. We can custom tailor for patients with endo, with adeno, shapes of the uterus that are abnormal. There are many ways that you can make the journey better for patients so they're not having to do 6, 8, 10 embryo transfers. And that's what should come out of that study. Yes, you can get there, but you're going to get a much better satisfaction from your patients by not torturing them, bankrupting them, and making them be emotionally devastated, having to go through 10 transfers to finally have one single pregnancy. We should be able to do it in 1. We can do it in as close to 1 as possible, and that's what the goal should be, not 6, 8, or 10. So I wanted to share that with you. Also, a huge thank you to one of the readers from the Crazy Vitamin K posters who truly demonstrate the depth of ignorance for all the posters that are out there who are saying things like the new one who insists that it's just fine for mom to eat lots of green leafy vegetables because the vitamin K will get through her baby. It doesn't go through breast milk. It doesn't. It barely gets in enough breast milk, and the baby can't absorb it from the breast milk. So you're not getting vitamin K from your breast milk. And she claimed to be a pediatrician, but clearly has absolutely zero medical knowledge, which is terrifying for me. That now people are just making false claims about who they are and what they are. Nevertheless, one poster said that she appreciated all the information we provided and had changed her mind from not giving the baby vitamin K to giving the baby vitamin K. So great, huge bow down to you. Love the fact that you're able to see through everybody's BS, actually look at facts and make a rational decision that will protect you and your baby. So I love that about it. Thank you very much for that. I'll probably anonymize that and put it up as a separate post for everyone to see, but great for us because I put in countless hours of responding to unhinged lunatics who believe that vitamin K is bad and dangerous, when in reality it's the opposite that's true. It's life-saving and needed for babies. So for all those people out there that are saying it's synthetic and it's terrible, please go have a look at our posts. It doesn't matter about it being synthetic. It is a life-saving medication with 60 years of use and billions. I actually had ChatGPT look this up. Billions of doses administered. Not 1 or 2, billions of doses administered with one reported case of non-fatal anaphylaxis. That is the only complication ever mentioned in the entire literature. So, with no further ado, tonight we are going to share what's on my screen. Have you got it there?
I got it.
So this is the Society for Maternal Fetal Medicine, and they looked at management of pregnancies resulting from IVF. So this is hugely important for those of you who have an IVF pregnancy or are about to have an IVF pregnancy. I want to know, is this more risky? Is it the same? Are there differences? What do I have to worry about? So they convene a whole group of doctors and they put them together for this. I have to admit, I don't know any of the doctors that were involved in this guideline, but they pulled them together, they review the evidence, and they synthesize it according to a scale or grade of the evidence, and they then talk about specific issues. So I'm just going to highlight those for you because it's way too much data. We would be here all night if we go into this in great detail. But I'm going to go through it step by step. So I'll show you the questions and then we will talk about what the answers are. So they say, what genetic conditions should be discussed with patients considering to undergo or who have undergone IVF? And the answer is there is a specific rate, they say about 1.5% of abnormalities in patients needing IVF. So for those patients that are undergoing IVF, some of you actually may have a genetic abnormality. It's not going to be common. It's going to be very rare, low percentage, but it's enough that they actually summarize it by putting it here and saying, we suggest that genetic counseling be offered to all patients who are undergoing or who have undergone IVF with or without ICSI. So this is important because they've even done genomic imprinting and looking at different studies to determine if there is an association between various syndromes, various conditions. And so they're actually suggesting it's a reasonable consideration. We do have built-in genetic counseling in our program here at BRC. We have for a while. We use a company called Genomic Care. And likely in the future, we will look at options that just have an in-house geneticist who can help people all the time. We are about to get our PGT program up and running on our own, which hopefully will make things more efficient and maybe even a little bit more cost-effective than they already are for those of you that are desperate to do PGT but don't want to spend quite as much. So we're really excited about that as well. What are the different types of pre-implantation testing? So obviously there's PGT-A, you all know that. That's the normal one where we're looking for the number of chromosomes. There's PGT-M where we're looking for specific genes on a chromosome, cystic fibrosis, muscular dystrophy, PEX disorders, all sorts of different genes, Huntington's, these can all be evaluated. And then we have PGT-SR, which is where you're actually determining if there is a balanced or unbalanced translocation on one of the chromosomes. There is now also PGT-AI, which is artificial intelligence. And now we have whole genome sequencing. We will have a friend of mine from the Juniper Genomics company, Jeremy, on with us, and he is going to talk about what they have to offer and what the purposing of that new technology is and how useful it can be. So we're really excited about that because we've started sending some cases. We're going to get answers to questions we never had answers to before, like why are you failing when you have a euploid embryo? Is there something wrong that is never going to allow you to conceive with your genetics? And that's really critical. So with all the PGTs that are available, they say regardless of whether PGT has been performed, we recommend that all patients who have achieved pregnancy with IVF be offered the options of prenatal genetic screening and diagnostic testing via CVS or amniocentesis. Now, I will say I disagree with them here. Even though it's very high-level evidence, it's expert opinion, it's C, based on a review of existing data that's randomized controlled trial. So the problem with this is nobody that's going for a IVF pregnancy is going to want to have an amniocentesis unless they're at risk based on NIPT or enhanced first trimester screening tests. So I personally wouldn't go with this. I would start with the enhanced first trimester screen if your age is appropriate for that, or the NIPT. In Ontario, it's free for patients over 40. But we would definitely recommend amnio or CVS if there's something wrong. Other than that, should we be doing something that has anywhere from a 0.5 to 1% miscarriage risk? No. Why would we do that to a perfectly healthy, happy pregnancy after you've struggled so hard to get there that wouldn't make any sense. But it does make sense to make sure people are tested to the best of our ability to keep it safe. The next question, what is the accuracy of first trimester genetic tests in patients who have achieved IVF success? So this is the testing with enhanced first trimester screening or using cell-free DNA, which is the non-invasive prenatal test or NIPT. So the tests are showing that there is an increased risk of false positives for aneuploidies in patients who undergo first trimester screening. You can get a lower fetal fraction in patients that achieve success with IVF. So there may be some differences, and it's subtle, like you're looking at the difference between 5.2% and 2.2%, but they are there. But it's pretty reasonable, and overall, there is a pretty strong correlation if you have to repeat the test to double check. So they do say we recommend that the accuracy of first trimester screening tests, including cell-free DNA, more commonly known as NIPT, for aneuploidy be discussed with patients undergoing or who have undergone IVF. And that's based on randomized controlled trial data. So this is something that's important for you to be aware of when you're undergoing this. Does multifetal pregnancy reduction reduce the risks associated with multiple gestation? So this is critical. If you achieve twins or triplets, and it's really focused more on triplets, if you select, excuse me, to reduce, meaning you're terminating one of those pregnancies, one of those fetuses, to reduce down to a singleton of twins, does it protect you? So there is no question that we want to limit the number of pregnancies that have high order multiples. How do you do that? Stop transferring more than one embryo, which we very strongly try here at VRC. It's rare that we do 2. It was another recent post, and we certainly never will do 3. So it's very rare that we're getting high order multiples because normally we're just transferring 1. We've never had 1 split into 3. We have had them split into twins. Generally speaking, it's very rare. It happens to about 1 in 300. And so the risks are pretty slim. But if you put in 2, can they split? Yeah, and you can end up with triplets. And in one case, we actually had each of the embryos split into identical twins. So we actually ended up with quadruplets, which is not good. So that's definitely a significant thing. So there is an increase in risk of complications. And so when multifetal pregnancies do occur, they do want you to discuss the option of reduction. They do say that it has been shown to reduce the risk of preterm birth, neonatal morbidity, and maternal complications, but this is generally going from triplets to twins. Very few places will recommend that you consider producing twins because it's generally speaking fairly safe. I did deliver a set of twins last night of my own who had made it to 33 weeks, but they do come early, and they did last night. She broke the water for penguin boulders. So there is definitely the situation in which we have babies that come early when they're twins, definitely more so when it's triplets, quadruplets, that kind of thing. They will recommend consideration of reduction. So something for you, those of you who end up with more than one baby, to think about. We certainly will offer you your options. It is rare that we will encourage someone to reduce if it's just twins, but we do offer them the option if it's triplets, and certainly quads, they will strongly recommend it because there are very, very few successful cases of quads making it to a reasonable point in the pregnancy where they're not endangering the life of the babies. Are congenital anomalies increased in pregnancies with in vitro fertilization? So, of course, this is the thing everybody wants to know. Well, we do know that the background rate is 2 to 3%, and IVF might slightly increase that, but it definitely increases it when you're looking at ICSI cases. It goes up about 1 or 2%. So we are worried about that a little bit. So they do recommend detailed obstetrical ultrasound examination be performed for pregnancies achieved with IVF and ICSI. That's automatic in Ontario. It's automatic in every place in Canada. However, there is a higher risk, and they actually do say that there's higher risks of heart disease. So they specify here that in the background rate of the population, it's 0.68%, but in IVF pregnancies, with or without ICSI, it was 1.3%, so double the rate. And that's enough, but they say that you should actually look at whether or not that exists. So they actually are recommending that we suggest that fetal echocardiography be offered to patients with pregnancies achieved with IVF and HC. Now, we're not automatically doing this for everybody, but I think we need to now. I think we actually need to pay a little more attention and say to patients, if you achieve your pregnancy with IVF, if you would like, we can offer you an additional test. We have to get permission for this, so we're not there yet. This is something we need to talk to the hospital about and so on, but this is something that needs to be considered. I'm not saying we, VRC, but we as a program, fertility providers who are also covering obstetrics or obstetricians need to actually look at this and say, should we see if there's a way that for IVF pregnancies, they will allow us to start ordering these routinely if we are worried. So I do think it's worth considering because it is in these guidelines. Not super high level evidence, it's mostly expert opinion and it's based on grade 2 evidence, but it's something to be considered. Again, it's going to affect a very small proportion of you, so not everybody needs this. And certainly if the basic evaluation showed no abnormality, you probably don't need to go beyond that with a more detailed view. And that's generally the case for us. Are placental anomalies increased in pregnancies achieved with in vitro fertilization? So these would be things like accreta, percreta, placenta previa, abnormally shaped placentas, and so on. So pregnancies achieved with IVF are associated with higher risk for abnormal placental shape. They're at higher risk of having placenta previa, 172% increase for that is very significant. And it may be even higher if it's with a blastocyst transfer than if we do it on a day 3 transfer, and much higher than comparing it to a naturally achieved pregnancy. There's higher risk of the placenta having the cord inserted either at the edge or kind of off the placenta, which is concerning, marginal cord insertion or velamentous cord insertion. And even things like vasoprevia can be increased, and vasoprevia is life-threatening for both mom and for baby. So these are all very significant risks that we worry about, and given those risks, we want to make sure that we are very careful with these patients. Placenta accreta, percreta, those are also increased. So they do say we recommend that a careful examination of the placental location, placental shape, and cord insertion site be performed at the time of detailed fetal anatomy, ultrasound, including evaluation for vasoprevia. This is very high-level evidence, 1B. So this is an automatic, and thankfully, almost every radiology center I know of does look at this in every pregnancy, so it's not something new to us. We know what about. Is the prevalence of spontaneous preterm birth, so preterm labor, preterm birth, higher in pregnancies achieved with IVF? So it is higher, even if it's just one baby. So that's something we need to look at. And that's why here at VRC, we keep our patients on progesterone because it reduces the risk of preterm birth. So we know that even through meta-analysis, pregnancies with IVF had a doubling of the risk of preterm, low birth weight and very low birth weight when compared with naturally occurring pregnancies. This is huge. That's why we keep our patients on progesterone, because I want to avoid the risk of my patients delivering early. And thank God, knock wood, or listen wood here. It looks like we do a very good job with that because we have a relatively low rate of preterm birth in our singleton IVF pregnancies, which I'm very pleased with. So the specific IVF techniques may be important, and we do know that when you're using high estrogen protocols, if you're doing a fresh transfer, those things are associated with higher risk compared to doing frozen embryo transfer. So what they say is, from this, you got to watch patients, but what they don't say is that you should monitor the length of the cervix. So they actually say, although visualization of the cervix at 18 to 22 weeks of gestation with the general anatomy scan is recommended, you do not recommend serial evaluation. So you do the one cervical length during your anatomy scan. If it looks good, they're not telling you to repeat it over and over again. Now, they say progesterone is not indicated solely based on IVF, but again, I do disagree with them on that one. I do think it's useful and that it should be continued because I do believe that it's useful. And interestingly, despite the fact that they say here it's not indicated, they don't provide a single reference. So there's no question we know progesterone reduces preterm birth. Why wouldn't IVF pregnancies more so than in any other quality growth? Is the prevalence of fetal growth restriction higher? So IUGR, small for gestational age, these are really little. And it does say, absolutely, it is there with a 40% increase to 60% increase in meta-analyses. You are going to see smaller babies, growth restricted babies. The difference in weight with or without ectasia naturally exists and continues for between 0 to 4 years. So these can actually stay there, but it tends to disappear after the kids are 5 years of age. So that's kind of important as well. And based on that, they say, and this is really critical, they do recommend that we assess the fetal growth in the third trimester to see if the babies are growing appropriately, but you don't need serial growth ultrasound. So we do that for things like twins, triplets, and so on. And certainly if we identify an IUGR baby, that's something we would do. We're not doing it for all pregnancies. And so this is something that needs to, again, be looked at. We need to consider whether or not there's value in actually doing a third trimester growth ultrasound for all of our IVF pregnancies. What about baby aspirin? Does that help? So they do bring up all the data. It definitely reduces the risks of preeclampsia. We know that, and that's helpful. There are higher risks of preeclampsia in babies who have IVF. They say that meta-analysis did not find a significant reduction in the rates of hypertensive disorders in pregnancy with low-dose aspirin achieved with IVF. However, these are people starting it after. They don't have data on people that start the aspirin like you do before we're doing the transfer. And that's why it's so important, because the timing is everything. Because preeclampsia initiates as the placenta is formed to the uterus to establish the blood supply. It's an imbalance between two chemicals called thromboxane and prostacyclin. And because of that imbalance, you end up eventually developing preeclampsia. The reality is, if you don't have the aspirin on board early, you can't alter that imbalance. And because you can't alter the imbalance, you're going to end up with preeclampsia. So starting the aspirin later might delay it, but it's not going to prevent it. The aspirin has to be on board early. And we know that other studies have shown reductions in preeclampsia by using the aspirin. So this is something we recommend. There's also other advantages for women that are older, not mentioned here. So those are all very, very important. So they do say the United States Preventative Services Task Force states that IVF is a moderate risk factor for preeclampsia, and they recommend low-dose aspirin if additional moderate risk factors found: age, obesity, history of high blood pressure, quite frankly, infertility. So I think it's important. We do not recommend low-dose aspirin for patients with pregnancies achieved with IVF as the sole indication for preeclampsia prophylaxis. However, if one or more additional risk factors are present, it is recommended. I would say infertility is a risk factor, so go for it. Is the prevalence of stillbirth increased in IVF pregnancies? I don't want to spook you all, but the answer is it's a 2 to 3-fold increase for stillbirth, even after controlling for maternal age, number of pregnancies that we've had, and having multiple gestations in there. One meta-analysis found 11.8 per 1,000 with an odds ratio of 2.6, which is roughly 160% increase achieved in pregnancies with IVF versus naturally pregnancies. And it doesn't matter if it was frozen or fresh embryo transferred here. They're saying that it is definitely worrisome. However, there's some debate about this. So they do say that given the increased risk of stillbirth, we suggest weekly antenatal fetal surveillance beginning at 36 weeks of gestation. So should we be ultrasounding or doing an MST or just listening for the heartbeat? They're not specific, but we obviously listen to the heartbeats. Maybe it's time to go a step further, look at ultrasounds and so on. So that's something, again, we're going to have to define as a practice, and we're going to have to look at. It's not something we're implementing now, but it is something that they're recommending you look at. And so every practice will have to decide for themselves. Again, it's fairly weak evidence, and the C grading for this means it was mainly expert consensus. In pregnancies achieved with in vitro fertilization, does delivery at 39 weeks of gestation reduce the risk for adverse perinatal outcomes? So they say that there is not enough data to support that because they're using a systematic review. However, there is only one really good randomized controlled trial of induction of labor prior to 40 weeks, which is the ARRIVE trial. And in the ARRIVE trial, it is abundantly clear that there is a reduced risk of cesarean section and reduced risk of complications, both individual and their composite adverse outcome. So you'll have less stillbirth, which is critical because we just told you you're at a higher risk of stillbirth. you're going to have less preeclampsia, less NICU admission for the baby, less ICU admission for the mom. These are huge, huge important outcomes. And so while their study basis for this is a systematic review, we do know that systematic reviews, if you include the wrong studies, can kind of be junk in, junk out. I think that's the case here because there is only one really well-done study. It is that ALIVE trial. So they say in the absence of studies focused specifically on the timing of delivery for pregnancies achieved with IVF, we recommend shared decision-making between patients and healthcare providers, of course, when considering induction of labor at 39 weeks of gestation. So yes, of course, it should be shared decision-making, but I tell all my patients to do it because your stillbirth risk is higher. And their own guideline says it right there. It says, given the risk of stillbirth, we're encouraging you to follow more closely and monitor every week, but we're not going to tell you to induce. Well, that makes absolutely no sense to me. If you're being told your stillbirth risk is higher, and we know it increases as you go up in gestational age, in particular when you go past your due date, then there's no reason not to induce when we know the satisfaction rates are the same or better, and that we are dealing with a lower risk of complications. So this is absolutely huge data, lots of changes, I'm sure. Lots of changes, lots of things that are super valuable for us to be aware of and to know. Certainly in our practice, we're going to have to take a look at how many of these changes we can implement because we're governed by the Ministry of Health here. But there are some things you can probably do and should do based on these guidelines, and we will look at that and start talking about how we're going to implement those over time. Certainly when we are ready for them, we'll let you all know. They're not there yet, but there is some material here that's important for people to know. In particular, this part about the induction of labor, because that is hugely important for people to be aware of. If you want more information about that, check out our YouTube video on induction of labor. It is crystal clear from the information we provide there that induction of labor is safer. Satisfaction rates are the same as not being induced, and the outcomes are way better for mom and fertility. So it's not a fertility fact or fiction, but I wanted to run through the guidelines with you so that you are aware of the things that you need to know about your IVF pregnancy, and so that you can take appropriate precautions to make sure everything's being done as safely as possible. I will stop there, and we can talk about whatever you guys want to talk about.
Well, they got questions.
I can imagine.
They got questions.
Yeah.
And they want answers.
All right. I'm here for answers.
All right.
And I'm starving because now we're way past our past.
Way past.
Yeah.
Way past. That took 2 seconds to finish up.
Didn't
last as long as I thought.
Because of the show. So Tart got a little something.
I was sneaking them in.
Yeah.
Would you recommend prednisone if Hashimoto's antibodies are low?
If Hashimoto's antibodies are low? No. So I just reviewed a study for a patient today, actually, earlier in the day, where it did show that adding steroids in does reduce the antibody levels and actually was associated with higher chance of live birth. But it's only based on the antibodies. Why would you do it if your antibodies were low? I don't think that wouldn't make any sense. So I wouldn't do it if they're low, but I would do it if they were high and I couldn't get them down with synthroid levothyroxine, selenium, and maltitol, things like that.
Here's a great question. Hi, Dr. V. My RE told me to take DHEA 60 milligrams.
60?
Yeah.
It doesn't come as a 60.
Well,
okay, anyways.
That's the beginning of the conversation here.
Okay.
I started having really bad headaches and dizziness.
Oh.
I tested it at my DHEA is 6.224 higher. Other hormones are okay. How do I get rid of the headaches? I stopped taking DHEA after 2 weeks, but it's still weeks since I stopped and I still have headaches. Also, do you think I can continue with IUI with high DHEA and the headaches?
I would get your headaches checked out. I mean, that's not a typical side effect of DHEA. So my advice to you would be to go see your primary care physician and make sure they're evaluating you to make sure that there is no other pathology going on. I've never had a patient come here and complain about headaches from DHEA. So go get your headache checked out, please, right away.
Part 1.
Part 1. It's like Dune, part 1. All right. That was like a lot of drama.
I thought you'd like that.
Yeah, all right.
Age 32, AMH 37, AFC 22. but only got 10 eggs in the first ER and 8 eggs in the second. Double trigger stimulated for 10 to 11 days. Estrogen value corresponds to exactly 8 to 10 eggs. Doc wants to try and this is part 2, Lupron start agonist protocol next time. What are your thoughts?
Risky, because if the Lupron start gets your eggs to grow, I don't know if they're talking about long protocol with Lupron, but if they are, if your eggs start to grow and you then have to use HCG, so if you do get like 20 eggs growing, you're going to need an HCG trigger, and an HCG trigger is going to give you a very high risk of hyperstim. So I've been more interested in knowing what dose they use. Did they use birth control pills first for priming? Did they do anything to suppress you ahead of time? Did they try something simple like testosterone, which can boost the number of eggs that are growing? Or growth hormone. So there are other ways to do it before you dive into a Lupron, but I would need to know more details about specifically which Lupron approach they're going to take and how are they going to manage your trigger. So those are the important things. The other thing that's critical is what was your dose? Did you use, 75 going left menopause? Of course you're not going to make 90. Did you get a medium dose, 150, or did you get a high dose? So I would need to know what your dosing was, what your climbing was, where you suppressed, things like that. Great question.
Love your show and how thorough you are with your answers.
Thank you. I appreciate that. We love doing the show. This is a labor of love for us.
Yeah.
I'm getting harangued on the vitamin K post about being on the take. Apparently, people think erroneously that somehow I get paid by Big Pharma for administering vitamin K. Never made a penny from vitamin K. I actually literally had to ask Tarek if our Instagram is even monetized. He said no. So we get nothing for talking about vitamin K. I don't get paid for administering vitamin K. I don't get paid if a nurse administers vitamin K. I don't get a kickback from Big Pharma. There's no insurance company in Canada. I'm not even making money for my damn post on Instagram or the I don't know, what is it, 1,400 comments that I've now had to answer. There's nothing in it for me other than protecting babies. And same thing with this show. The only thing that's in it for us for doing this is helping people. You guys have seen the posts we put up. People get help by us for free or just read stuff that we put out there and they improve their journeys. And that's like a moment of pride for us. We love the fact that people are more successful. I profit from people that come here and do fertility care with us. Absolutely. Like any other medical clinic providing private service. Yes, of course, there is money that's being made here. And I'm very open and transparent about that. But we will never do anything that is not in the best interest of the patient. Never. Or in the best interest of your safety or your baby's safety. It will always be about that. And I'm proud of what we've done with this show. I think, honestly, you probably have the best fertility show on the web.
It's an amazing show.
We actually give people the answers that they need to make their journeys better.
You don't find it like this anywhere. I'm telling you, you don't find it like this anywhere. So that was a segue into her question. That was just the beginning part. I love your show.
Okay.
And how thorough you are. My TSH is between 2.5 and 3.
Okay.
Endocrinologist says I don't need meds. RE wants me to be on 25 milligrams of levo. Can I balance it naturally?
No to the naturally part to the best of my knowledge, but you'd have to talk to like a naturopath. I don't know how to balance your thyroid that way. I disagree with your endocrinologist. I agree with your RE. You should be on 25, not milligrams, because that would kill you. You need to be on 25 micrograms of simple level pyroxene. Yes. 25 milligrams would probably be the dose for an elephant. But 25 micrograms would be fine. Yeah.
What are your thoughts? Of course, this is all to you today. Today there's no
Dr. T.
No Dr. T at all.
Yeah, I'm sorry about that. But you have a really cool car to make up for it. So that's okay.
I just opened the garage and I look, and then I close the door again. And then I open the garage again, and I close the door again. I'm seriously considering buying a cover. I feel it's just too exposed.
Oh, yeah.
Gotta get a cover, right? Yeah, gotta get a cover.
Yeah, I'll tell you what you do.
Okay.
Yeah.
Dr. V.
That's me.
Yeah. What are your thoughts on mini Lupron 10 units starting on CD2 and adding Gonal-F and Minipur on CD3 with estrogen priming for someone with suspected endo?
Well, microdose fluoroleucone is a great protocol for an endo patient because their ovaries are typically weak, and it will help boost the production of your eggs. So I would strongly support that. We can't get it here anymore, so that's our problem. But like, I love the idea; it's a fabulous idea. Estrogen priming for someone with endo, that's the same anomaly or abnormality where you're pouring fuel onto a fire and then hoping that it's going to be put out. That doesn't make any sense. So endo is an estrogen responsive disease. Why would you take estrogen right before you least want stimulation? And you're going to jack up your own natural estrogen levels. That just makes no sense to me at all. So I wouldn't recommend that. And studies support that there's no benefit to estrogen priming. So in a non-endo patient, it's useless. It's got to be detrimental in an endo patient. So we don't do it.
Is an AMH of 4 good? FSH7, LH3.
That depends on whether you're talking about 4 nanograms per mil, in which case that's an excellent AMH, or you're talking about 4 picomoles per liter, in which case that's not an excellent AMH, that's actually quite low. So it depends on the units. NG per ml, good. PMOL per liter, not good.
Hey, Dr. V, for someone with RIF, which uterine wash would you recommend? HCG, Neupogen, or PRP? Thanks.
So we'll probably review that on one of the upcoming shows. There's a brand new paper out in Journal of Assisted Reproduction and Genetics, and they have a systematic review of 25 randomized controlled trials. And in that, it said it was PRP first, which is way ahead of the others, then Neupogen, then HCG. And Neupogen and HCG were very close to each other. We've been doing the PRP with tremendous success for a while. I love it. I wish it was cheaper. It isn't, but it's a great option for patients. Great option. Yeah, love it. Works really well. Somehow we got to work on getting the price lower so we can do it for everybody.
Dr. V and Dr. T.
Oh, there you go.
There we are.
Yeah.
Can you please explain what a spindle scope is and how it can help? Does your clinic use this technique?
So we don't use it here. I'm not a believer in the data from it yet. I don't think it's strong enough. There's one clinic in Toronto I know that does it. I don't know of anybody else. So it's a microscope that allows you to see the mitotic spindles, which are the parts that help pull apart the cells when they're dividing. Supposedly by looking at that, they can gauge how good the embryo quality is and what's going to happen with it. I'm not convinced by the data, so I don't think it makes enough sense for us to do that. We are getting some super cool technology for sperm assessment that could be a massive game changer, and that I'm very excited about. But it's going to be a while before it arrives here. I'm still waiting.
All right. Dr. Victory, I appreciate everything you guys do here and at your office. Thank you for everything.
Oh, nice.
Is the embryo department, I'm not sure the first word. I thought it was is, then it's written ID, but you'll know. ID, the embryology department says on the day 3 that it seems like about half the embryos seem to have fragmentation. Are they doomed or to arrest or fail?
Yeah, so if you have fragmented embryos on day 3, there's a much higher risk of failure to achieve blastulation, for sure. So that means they're already beginning to degrade. It doesn't mean they universally will, but it's a warning sign and it's worrisome, for sure.
Oh. Not a horrible honest. What would be the best time in the cycle for endometrium biopsy test? Please. Never.
Ever biopsy your endometrium. There's not one single reason to biopsy the endometrium. Studies that have looked at endometrial scratch conclusively show that it's pretty much useless. Studies that look at endometrial biopsy to determine your chance of having endometritis show that it's useless because there's only a 50% inter-observer variability, so meaning it's a flipping a coin as to whether or not pathologists agree on if you have or do not have the markers or the signs of endometritis. And doing it for the ERA test is actually detrimental because we know the ERA test will reduce your chances by as much as 13%. So there is zero indication to ever do an endometrial biopsy in a patient who is undergoing fertility treatment unless they are worried that there is endometrial hyperplasia or cancer there. Aside from that, do not do an endometrial biopsy. There's no indication for it. No one can justify it, and I'll happily challenge anyone to a live debate on it.
That'd be great.
Which also reminds me, I challenged one of the unhinged to a debate. I said, you believe so strongly in all your stuff.
Yeah.
Come on the show and debate me.
Let's do it.
It was the only way I could shut her down. That's the only time she stopped.
She didn't stop.
I said, come on the show. You're so sure of yourself. Come debate me.
Oh, wow.
Yeah. Nothing.
Just
finally shut up.
Yeah.
There's
Sometimes
no
you just got to do it some way.
Yeah.
It's a duel.
It was crazy.
You had an internet duel.
Yeah.
Hello, Dr. V and Dr. T. Just wondering if donor versus spousal lit is better if time is limited before transfer. How do you check to make sure the donor is not a DQ or KIR match?
We don't check for KIR match. That's not something we would do. It'd be very expensive to do. What we basically do is start with the partner, and then if it doesn't work, we go to donor. Keep in mind, donor lit's like a lot more than autologous lit is. So we don't love doing it. Yeah. We try and avoid it.
Does it work? The same?
Plus, we have one poor bastard with a cute trip.
Oh, it's taken him from, eh?
It's the same guy every time, and I love him to bits. He's a really nice guy. He is associated with our staff here, so we know he's clean and healthy, and we test him for STDs all the time. Nobody's had that many STD tests in their life, but I literally have to give him a break because, like, we're gonna see his iron and hemoglobin go down soon. We're like vampires.
Part of the job at this point.
Yeah. Yeah, so we do autologous first, which is your partner, and then if that doesn't work, we go to the donor with it.
All right. Here's a question.
Okay.
Can doing IVF
Yeah.
cause breast cancer?
This is being very thoroughly studied, and the answer is no. There is no definitive evidence that IVF increases risks of breast cancer. The data so far from a cancer perspective for IVF actually shows it's beneficial for breast cancer because if you're successful and you have a baby, which is the key, breastfeeding and pregnancy are extremely beneficial for reducing risks of breast cancer. So that's huge. Is there any cancer risk with IVF? There is an increase in the risk of something called borderline ovarian tumors. So borderline ovarian tumors are a special type of ovarian tumor, which is not a cancer, but it's not a cancer. I know it's a horrible way to describe it, but they can spread, but they don't tend to invade into the tissues. They can be problematic though, because they can spread and cause adhesions and scarring and organ dysfunction, especially if you have the serous versus the nuisance type. So yeah, we worry about those, but they're very, very rare. And I've never seen it other than I think once in my whole career in an IVF patient. So I'm not seeing it often enough for me to be worried about it, but it is the one and only risk from a cancer perspective, and even that's not a cancer. So that's what we know about the cancer and IVF story. It's been studied extensively. There's all sorts of research on this.
Hello, Dr. V and Dr. T.
Oh, there you go. You got a freebie.
Here we are. I've been diagnosed with an MTHFR gene mutation.
Yeah.
I have to do IVF. My doctor has suggested Clexane during pregnancy. When would you suggest is the best time to start Clexane?
2 days before your transfer, a couple days before your transfer. That's easy.
That's easy.
And use 5-methylfolinic acid rather than folate.
Thoughts on rapamycin and red light therapy before doing an IVF?
Rapamycin has been shown to be beneficial for IVF patients who have endometriosis. I haven't seen any studies on non-endometriosis patients, but in the endo patients, it is significantly beneficial. We've reviewed that on the show several months ago. More than that.
Yeah,
six to 8 months ago.
Okay.
So that's huge. In terms of red light therapy, there are a lot of studies on red light therapy. They do actually suggest a possible benefit. Does it work? I don't know. We probably need to do a randomized controlled trial, which I don't know how you even do that. What's that, like white light therapy versus red light? But it's something we're looking at. So I'm considering offering it to patients. It's kind of up there with the hyperbaric oxygen and stuff like that. We just don't know if it works, but tacrolimus, sirolimus, yeah, for sure, rapamycin, those definitely benefit. There's no question.
For the hyperbaric chamber, what's the theory behind it?
You're driving oxygen and oxygen spirit.
Oh, that's it? Just more oxygen?
It's like
Better.
Instagram getting more posts.
Yeah,
feeding the beast.
to put it politely, yeah. So just more oxygen makes everything better in the body. That's the theory.
So,
Mm.
unless you go toxic,
Then it's too much.
That's
Yeah.
not good.
Which bacteria on the Fertility microbiome suggests chronic endometritis, and what treatment do you recommend for those bacteria specifically? Thank you.
Any of the bacteria can represent chronic. So it comes in groupings. So the first grouping is like all the real hardcore STDs, chlamydia, gonorrhea, and ureaplasma, so we tailor it to whichever one it is. The second grouping is what they call the facultative anaerobes, and those ones we treat with amoxicillin clavulanic acid or moxifloxacin. And then the next one is the obligate anaerobes, so your Gardnerella and Prevotella, Trichomonas and all of the Athapobia, Mobiluncus, all that stuff. So those ones we treat with metronidazole or clindamycin. So it depends on which category you're in. And then you got to remember that all these bacteria are really good at wrapping themselves in a gel coat, which prevents them from being attacked by the antibiotics. So first you need to break down the gel coat. So we use boric acid, and now we've added NAC in for that. And then you got to use antibiotics, and you got to use it for a long time, and you got to treat the partner. And then you've got to also use super high potency probiotics to fill the spaces from all the bacteria that you're killing with the good bacteria instead of the bad bacteria.
Thoughts on PGT testing?
Well, I got to be careful because the PGT companies are getting sued and I'm starting my own. So PGT testing is technically supposed to be used to rank embryos. If you look at the data on this, we know that it is cost effective. So they don't have a properly conducted randomized controlled trial to show that it's beneficial. But cost analysis shows that it's cheaper. A great example is that study I mentioned at the start of the show. 6 to 10 untested embryos, and the max number that they got was 78% implantation, with 10 embryo transfers. In a separate study, which looked at PGT, 5 embryo transfers of PGT normal embryos got you a 98% live birth rate. So we know for sure you're going to be cost effective because it's half the number of transfers. And transfers are way more than the PGT is. So cost effectiveness is there. There's no question. From the standpoint of efficiency, there's also studies that show that the time to having a live birth is shorter. So that's there as well. It's more efficient process. From the standpoint of, is it accurate? Not entirely. So we know that mosaics can be normal. We just delivered our first high-level mosaic embryos, so that was great. We know the low-level mosaics are normal or have the same chances as a normal, so that's fine. Go ahead and use them. And we know that some of the complex aneuploids can actually come back as normal when we test them. So we are offering that testing to patients now who have complex aneuploids, because this is brand new data that came out saying if you do have a complex aneuploid, you may actually have a euploid embryo and the test just didn't work. Have we done it? Yes. Are the results terrifying? Yeah, they actually are terrifying. Some of those embryos are coming back normal. So if you have complex aneuploids, some of them could be normal. Also, if you have a segmental aneuploid, meaning just a portion of the chromosome of the embryo is abnormal, they're saying some of those embryos could be normal too. So we're not supposed to use this to just toss embryos or not use embryos unless they're true aneuploids, like you've got a Down syndrome baby or you've got an embryo missing a specific whole chromosome, and over 80% of the cells that you've tested show that. But we are supposed to use it to rank the sequencing of the embryos, which is how we get to less miscarriages and faster time to pregnancy by choosing the right embryos to begin. It's not supposed to be designed to just tell you toss all these embryos. That was never the intent. We've done that in the past because some of them are truly unusable. Keep in mind that with true aneuploids, we have a 0.7% chance that you're going to have a normal wide birth. Not great. Not worth the time or the money for doing the transfer, in my opinion.
Hey, Dr. B&T. RPL, PGT normal, endo, adeno, did fertilizers and endo protocol for last transfer, ended in chemical. I had a lap 5 years ago. Should I do another? Very low AMH and high FSH impacts.
I'd have to know if you did it with us or not in order to advise you of that, but certainly it's worth consideration. I mean, when people say endo protocol, I don't know if they're talking about my endo protocol or somebody else's endo protocol. So depending on which one you're referring to, maybe. Our endo protocol is pretty strong. I rarely tell people to go back and do another surgery. 5 years is a long time. Could we find endo we can clean up? Sure. It's not an unreasonable consideration. And certainly one I would consider offering to you if you failed a deployed embryo transfer.
I'm 37. I have PCOS, AMH 14.8, and 3 miscarriages. I did 1 IUI with letrozole, didn't work, but got pregnant naturally. The cycle ended in miscarriage. Doc wants me to do IUI with Puregon. Would you agree?
No. I would tell you to figure out why you're recurrently miscarrying and who told you you have PCOS with an AMH of 14. If you're talking about 14 picomoles per liter, you do not have PCOS. So that whole story seems very confused to me. IUI does not help solve miscarriages at all. There's no evidence that IUI will reduce miscarriage rates. And what you need are answers rather than more therapy. So before you go paying money for someone to do an IUI on you, you need to find out why you miscarried.
Good answer. Good answer. Hey, Dr. V.
Lots of little viral clips.
I heard it. I heard it. I'm like, oh,
Yeah.
I like that. Dr. V, very tricky question here. Which surgeons do you recommend in Canada for laparoscopic isthmus seal repair?
Anybody with expertise in advanced hysteroscopic techniques. So myself in London, George Velos, who's the god of hysteroscopy, is amazing. In Toronto, there are several who could do it for you, probably many. In Ottawa, Dr. Soni Singh could easily do that for you. He'd be amazing at that. I don't know everybody else across Canada. Yoav Brill could do it. Grace Liu could do it. Like I said, I don't know people west of where we are or east, but those are the ones I would trust around here. There are many others. It's not a super difficult procedure if you know what you're doing. It does require knowledge of what you're doing. So some people don't do it correctly. That's the problem.
Dr. V, I have persistent CE based on fertilizers. Multiple rounds of antibiotics for 1 month. Would the next step be uterine washes, and how effective are they?
Either that or seeing a naturopath. So we have had patients that we just couldn't fix, and we sent them to naturopaths, and the naturopaths fixed them. So I'm a big supporter of that. That's what I would do. How effective are the washes? They work quite well in our cases where we haven't been able to succeed otherwise, but it's not 100% by any means. Nothing is 100%. Microbiome is tough to fix sometimes. Urea plasma is a horrible, horrible wretch to get rid of. I don't like dealing with that. It's awful. Other things can be very, very difficult to balance out.
Should we try Pixie, Zymote, and calcium ionophore if we got poor fertilization with ICSI and Zymote, 1 attempt only? I'm 39, husband 36, no male factor.
I don't believe the no male factor part, so I would need to do advanced sperm testing, hyaluronic sperm binding, doing DNA fragmentation testing, looking at whether or not the survival of the sperm is adequate, and then looking at the oxidative reductive potential of the seminal fluid. So there is advanced testing we offer where we can determine if there's more to the picture than you know about already. You can even do sperm aneuploidy testing. That's available as well. So there's all sorts of tests we can do that will guide you. On top of that, Zymet is helpful. We use a better chip than the Zymet now, so I've given up on Zymet. We have other stuff that we use. Beyond that, a 3-hour interval with double ejaculation will really make a big difference because it drops your DNA fragmentation. And then we find that hyaluronic sperm binding actually makes a 10% difference in fertilization. So that's been huge for us as well.
Could you discuss how you use sirolimus or Tacro before egg retrieval, dose and how long? What type of patient would you use it in? And how often have you tried it? Success.
So I don't use it before. We use it as part of our embryo transfer protocol. I haven't started using it before IVF in people. There is a study that supports that use, but we just use it when we're doing the embryo transfer. The study looked at using 3.6 milligrams, which is hard because it only comes in 1 milligram increments. So I don't know how they did that, but basically you could use 3 or 4 milligrams every day, and they started 3 months before the IVF cycle.
I know you recommend taking melatonin as a supplement to include prior to starting treatment. However, what do you suggest if a patient is sensitive to this and doesn't tolerate it well, such as experiencing sleep disturbance and fatigue the next day?
Yeah, I think that person asked me the other day. Day before yesterday, they were asking about ashwagandha instead. I don't have any evidence that ashwagandha is a replacement for melatonin. So if you can't take melatonin, don't take melatonin.
Hypothyroid treated with synthyroid, TPO positive, endosuspicion on MRI, immunology normal though. Would I still benefit from an IVIG with Lupron suppression? My doc doesn't want to do aspirin or steroids.
So IVIG is kind of extreme for just thyroid antibodies. With regards to Lupron suppression alone for endometriosis is useless. That's proven. So no, that won't help you at all. And if your doctor's recommending that, ask them to provide you the evidence to support that because there's no evidence that that's beneficial. 2 minutes till food time. 3 minutes.
Hey.
Yeah.
Hey. Food time is a great time.
Food time is a great time. Yeah.
I have light brown spotting 2 days before my period starts. I heard it's due to low progesterone. Got mine checked one cycle 7 days after ovulation, and it was 12. Any way to increase naturally?
Naturally, no. Diet, there's some nutritionists that think you can increase your progesterone. I'm not aware of how well that works, so I don't. You'd have to talk to a nutritionist. There are some, you see them on Instagram every day. Got low progesterone, take this. But I don't know how well that works. I mean, it's related to follicle involvement, so I'm not sure how your diet's going to alter that, but I'm not a nutritionist or dietitian.
Hey,
Just tell me.
My family doctor believes I have blood clotting disorder and will refer me to a specialist. In the meantime, he believes this is correlated to my infertility. Have you seen this correlation before? What helps?
Well, blood clotting disorders increase your risk of miscarriage. So yeah, aspirin and heparin help. It's easy.
Easy.
You don't need a specialist. You just need testing. It's called a thrombophilia screen.
Thrombophilia screening. Boom.
Done.
Near the end here. Hi, doctor. I'm taking Flovita for my sperm motility. Is there anything else I can do to help improve my sample?
Yeah, ejaculate every day or every other day. No smoking, no drinking, no drugs whatsoever. Take those vitamins and keep your testicles cold. No cell phone in your pocket, no laptop on your lap, no hot tub, jacuzzi, sauna. Sit on frozen green peas for 20 minutes a day. Only feed them to your worst enemy.
At least it does for me, but everyone's different. I'd want you to take melatonin. Hold on.
That was melatonin.
That was melatonin, yeah.
That's fine.
What's a complex aneuploid?
More than 4 abnormalities of the chromosomes in the embryo.
quick one. Do you recommend vaginal and oral probiotics after taking antibiotics for endometritis?
100,000,000%. Not after, during. You need to refill it, even if some of those are getting filled. You need an overwhelming amount of the good bacteria to replace the space of the bad bacteria.
My husband's morphology is 5, motility 7D, and 70, and 55 mil per mil.
Yeah.
Million per mil?
Yeah.
Is this okay?
Yeah, it's not.
It's normal.
As long as the progression's good.
All about the progression.
Okay.
Can you treat microbiome issues while on endo protocol? I'm hoping to start endo protocol soon and retest for fertiliosis. It's being done next week. If you need, can you treat while on protocol?
No, you cannot, because I need you to have a period. And I'm going to thin out your lining on an endo protocol. So I'm killing your whole lining. No, you cannot do that. It won't work. You need to treat first or after, but after doesn't make a lot of sense because it can take a while to fix through microbiome.
Last question, final question.
Yeah, it's 9:01.
Did you suggest aspirin for blood clotting or something else? Sorry, I didn't hear it.
And heparin. Aspirin and heparin. So if you have a thrombophilia, we usually use both. We use aspirin and a heparin, but aspirin by itself is not sufficient. It's actually the heparin that's doing the majority of the work, the lion's share of the work. Okay, so next week, we will have Jeremy Grinshaw on, hopefully from Juniper Genomics. If not next week, the week after. We're just finalizing our schedule. And let us know if you are keen to see more interviews or more scientific articles, because we're kind of considering doing more interviews. Also, a huge shout out to the Sean Mike Kelly show. I was just out in Las Vegas to do their podcast and had a great time. Fascinating guys doing amazing stuff. Great interview. I'm very excited for that to come out in about a month and a half. Everything those guys do goes viral. So hopefully that'll help other people learn about us and know what we can do for them. In the meantime, please, dear God, go on the posts we have on Instagram and write stuff to the unhinged people. You need more than just me. Every once in a while, someone will chime in, but for the people that are just making false claims, they need to hear from the normal people that they're not right, that they're making false claims. So, help us in that endeavor, because I hate it knowing that other people are reading it and thinking, oh, maybe I shouldn't give my baby this or that because there might be a risk. I'm actually risking bleeds. I don't like risking bleeds. So hopefully you guys can jump on, give us your support. Lots of comments is always helpful. And let us know what resonates with you or what you want to learn more about. Have a great night, guys. Fertility Fact or Fiction.